involved in many, many projects that relate to pediatric mental health. She's an associate professor of pediatrics with Case Western Reserve University School of Medicine. And we are welcoming Kim. There's something I'm forgetting you want to tell people about yourself, please feel free. And we're going to
Sure.
get started.
Sure, thank you. I'm also a behavioral health co-chair for ASPR Region 5 for kids. I am the PPN, education, well, mental health is a subdomain lead for that, and then also an EIIC subject matter expert and part of the technical assistance program. So highly embedded in disaster preparedness and response. So today we're going to be talking about disposition and safety planning across the healthcare continuum. So the objectives, as Anna had said, it's really intended to be a discussion. So we want to identify strategies to prevent suicide, presentation to the ED and ED recidivism, identify and discuss application of the Zero Suicide Prevention Framework, considerations for discharge, and then also to have a discussion with you all about problem solving, any barriers that you've encountered, as well as what's worked well, and then future directions. Next. So I really feel that any discussion of suicide prevention, we really need to look at the whole healthcare continuum and start at community prevention. And so that's why I have this cycled here, because we start at the level of prevention, and then we will provide, and I'll go into greater detail, but then we would provide for those that we've identified as having particular risk factors, intervention components. We want to implement that before we get to the ED. Once we are at the ED, certainly we want to engage in discharge planning, have that safety plan in place. That of course, involves wraparound services and follow-up. And then again, we need to have prevention that the patient will arrive at the ED once again. And just to give you a sense of some statistics, and you might already know these rates, but just want to underscore that more than 20% of teens have seriously considered suicide. And this has been a sharp rise, and certainly a sharp rise more specifically in the Black youth, ages 10 to 24. 13% of high school girls have attempted suicide, and 30% have seriously considered it. 20% of the LGBTQ plus population has attempted suicide, and 45% have seriously considered it. And this is based on the most recent statistics provided by the CDC through the Youth Risk Behavior Survey. And moreover, in the same age group of adolescents, 57% of girls report persistent feelings of sadness, 29% of males, and then 69% of the LGBTQ plus. So it's just really important that prevention, we know these are the numbers, right? And so really have to embed ourselves within the community for psychoeducation, and then also to support these networks of relationships. Another couple more statistics. What we know is of those who do land in the ED because of a suicide attempt, 23% will reattempt. 7% will actually, when they reattempt again, will die by suicide. And so just taking in these numbers, and then 7% have no further attempt. So we really want to increase that 7% number. Next. So as I said, we have to look at the entire healthcare continuum and engage systems to prevent return to the ED. Next. So So you may have seen this graphic. I always like to use it when I'm giving talks about what are the systems of care and how do we assess and address those systems. And this is an AAP graphic. So as you can see here, all of these things come into play when we're considering prevention. So families, healthcare, public health, education, and you can see in these pathways, we also include diverse families. We look at all the stakeholders, establishing these strong partnerships. And the AAP developed a policy statement addressing all of these systems and identifying their critical role in emerging threats that can exist for infants and children. So again, not only prevention, but also when we are discharging patients, thinking about risk factors that exist in their world, and then also how can we bolster the protective factors. Next. Some of you may also be familiar more of the psychological, sociological theory from Bronfenbrenner. So he came up with the biopsychosocial model. And so I like to, whenever I'm providing intervention or again, safety planning, thinking about the patient in the context of this model. And so according to the model, there are 5 environmental systems that influence psychosocial outcomes. So we have, and you can see the individual in the middle, around the individual, we have the microsystem. So we want to think about as, again, risk and protective factors, friends, neighbors, family, school. We then look to the mesosystem. And the mesosystem consists of, more broadly, the neighborhood then in which you live. And then the exosystem consists of social welfare services, friends of family, mass media. And then the macro system consists of attitudes in general and ideologies. And then we go to the chronosystem, and that's in the time in which the patient is living. So thinking about how all of these systems interact with each other. Next. So does history really define destiny? And this is also a graphic that I really love to include here too, because we look at psychosocial adversity, right? And so even from infancy, we need to start pregnancy, right? We need to start thinking about this. And there's these sensitive periods for development. So we know that as you can see at the bottom of the graphic, that in particular, kind of the 6 to 12 months, we're looking at the HPA axis, 15 months, these critical milestones, language, 24 months, attachment, IQ, where we can really change some of the trajectory of if we are exposing children to adverse childhood experiences, toxic stress, how can we intervene at particular points in time? And so some adversities that we need to consider when patients are presenting to the ED, also, again, to prevent them presenting there due to suicide attempts. And then also in terms of wraparound services, we need to think about what's the family life like? So maternal stress broadly, parent psychopathology like depression. Does the parent engage in substance abuse? Is the parent present in the home, incarcerated? Looking at these depriving environments or child abuse or neglect very early on, we find that those who have attempted often have had a series of traumatic events or experiences or these psychosocial risk factors. And then if we don't intervene early on, you can see that there's actually biological change. So there's epigenetic changes, neurodevelopmental disruption, and there's actually a reprogramming of the stress and immune regulatory system. So we're not only talking about the environmental level, but the biological level. And so then that does significantly affect adult outcomes. So as you can see in the far right, that includes increased risk of cognitive deficits, disease, so physical health diseases, psychopathology, and and ongoing social problems. So it's all kind of interconnected and related. Next. This is the SAMHSA's continuum of care model. And so when we're providing intervention or services, we want to think about whether it's based on the hospital system broadly or specifically related to some of the work that you're doing. Where does this fall? And so this is how we had mapped where our services lie at Rainbow. So for example, for our prevention, uh, services, we have the Healthy Steps model, and I'll talk a little bit about that later, but it's a primary care prevention-based model for children 0 to 3. It's intended for high-risk families. So for children who have been prenatally exposed to substances, um, those whose parents are reporting caregiver stress and high parental depression. And then we also have different suicide prevention efforts in place in collaboration with schools. And then it just kind of goes on. And we look at the different levels of care. And one way that we keep children, of course, out of the ED or from needing to be, admitted to inpatient is to think about what level of care do they need within the community, and on the front end, how can we match that? So having school-based mental health services, engaging with community mental health centers. Sometimes we do need intensive outpatient or partial hospitalization programs. So thinking about all of those things within what's available within the context of your community, and with the ultimate goal of trying to keep the child, of course, at home, out of the ED.
Kim, may I interject just for 1 second?
Yeah.
It also allowed us to recognize all out of those 10 rectangles you see, there's like only one that is acute intensive services that um, we kind of oversee and close to, but it made us think of who are partners in the community and who do we collaborate with, what our advisory team should look like, who do we engage. So that model, putting it together and understanding who else are the players in the community and who are those kiddos are needed. I needed to support the most. We're learning a lot. It has to do with primary care providers and
Mhm.
other specialty services. That helped having this kind of model of it and drawing this out, mapping this out with this SAMHSA continuum model in mind. Thanks. Sorry about
Yeah,
that.
thank you. Thank you for mentioning that. So, I would say it's relatively rare that any one hospital or institution, can address all of these areas, right? And so it is identifying both where are the gaps within your institution, but then also going back to that slide I had shown from the AAP related to systems, right? So within the community, who do you need to partner with to help support the services for the child across, the level of need in terms of their psychological functioning. Next. So like I had said, there's really not, in my mind, a conversation you can have about safety planning and discharge without, in prevention, from presenting in the ED without thinking about prevention in general. And so these are the four main areas for prevention. So promotion, prevention, treatment, and maintenance. So when we look at promotion, we're thinking about at the very beginning what we can put into place to support behavioral health, just any sort of program that helps identify signs, symptoms. Maybe it's peer-to-peer coaching, just ways that we can support children within the community. Then when we get to the level of prevention, that's when we're trying to deliver care, but prior to the onset of a disorder. So prior to there even being a problem, we want to be able to reduce the risk of developing a behavioral problem or, substance use or abuse. Then at the treatment level, people have already been diagnosed. And so we're trying to provide evidence-based intervention. And then with maintenance, we're just trying to work on long-term compliance or adherence with what's been recommended, and then also providing them with the aftercare that they need so they don't need a higher level of care. And so an example would be like at school for promotion, anti-bullying programs in the school. That would be something that we're targeting and providing for everyone, right? And then prevention is if we know that there's a certain group that's at higher risk for mental health concerns or problems. For example, specific, if there's groups for LGBTQ plus youth, that would be something that we could provide coping strategies, right? So there's all these different levels and we can think about for different ages and stages in development. Next. So the zero suicide framework is pretty comprehensive, and I'm sure that you have looked into this previously, but it's when systems are leading cultural change, committed to reducing suicides. And so the goal is that we need to train a competent, confident, and caring workforce, identifying individuals with suicide risk via comprehensive screening and assessment, engaging all individuals at risk using a suicide care management plan, treating suicidal thoughts and behaviors directly using evidence-based treatments, transition those through warm handoffs and supportive contacts. We know that warm handoffs increases the likelihood of actually connecting with a therapist, staying with that individual for ongoing care, and then to improve policies and procedures and just continuing to reevaluate, look at through quality improvement, which is something I know that the PMHCAs have been guiding everyone through those processes and models. So at this point, and doesn't have to be specific to zero suicide, that actual framework, but it would be helpful to know as we go on in this discussion where specific interventions from your PMHCA teams, where are you intervening, or what kind of systems level changes are you trying to make? So for example, schools, or are we working at the level of primary care, um, community centers, peer-to-peer?
Hi. Hi, I
Thanks.
can answer this for Nebraska. So we have partnerships with the schools. We're working with primary care providers. With the EIIC support, we're really doing a needs assessment of hospitals and emergency departments. And so thinking about how that system connects with immediate needs and then where they can go from there. So transfer or home or treatment internal like in the clinic or hospital. And so we are still in the gathering information phase and the learning phase and probably will be until early next year.
Yeah, for sharing that. I know one thing that we've done in our system at Rainbow is we've done kind of like a geo mapping, and so identifying where we're at. Of course, we serve many of like the surrounding areas of Cleveland too, and identifying what the needs are within the community, and then community mental health centers, partnerships with mobile crisis units. So a large part is first undertaking what are the gaps, and then also who can we connect with, and how can we engage families in knowing where to access care. I see someone else had written in the chat, I need to pull back up, primary care. Let me see here. In Alabama, we have been primarily working with primary care providers, but are reaching to do training with schools. But most recently, we have reached out to some rural emergency departments to provide support and education. Yeah, that's so important because what we know is that nationally, more children will be presenting to community EDs than to children's hospitals. And so being able to equip or provide recommendations, education to those community EDs is critical, because then you can determine, right, who really meets the threshold for needing to be transferred to a children's hospital, for example. And then we're also doing work related to our primary care institute too. And I can talk to you a little bit about what some of those projects that are underway with that too as we move forward. We can go to the next slide. So one of the things is really having a standardized protocol for screening of depression within the medical home. And so we have moved to the Ask Suicide screening questions and using that toolkit, and that is mandatory. National requirements is to start at age 12, but we're really trying to push to start earlier at age 10, because again, we know that based on all the statistics, that children who are 10 years, even younger, are experiencing suicidal ideation. So again, we're wanting to catch these concerns, these risk factors, signs and symptoms early on, before we are needing a higher level of care. Other options certainly would be the PHQA. And then once presenting within the hospital system, I know many children's hospitals use then the Columbia Suicide Severity Rating Scale. So we know that suicidal ideation is occurring, and we want to obtain additional information regarding risks. And then the SAFE-T protocol is when, like in the medical home, it could also be used by therapists too, but what's the protocol for determining, is this someone that does need to actually be presenting to the ED? What I find is, and this is just anecdotal, but that the reason many patients present to the ED or are sent to the ED, it is kind of two reasons. So one, not being connected with mental health, and then two, having even mental health providers or providers from the primary care setting who they're getting care from regularly, but really a lack of knowledge and confidence about good safety planning. And then that leads to presentation at the ED, but not being admitted. And so then we've got issues related to extended boarding times, and then does that cause increased symptomatology? And so that's a question that everyone's looking into a little bit further. I also suggest that, although not mandatory or necessarily a best practice guideline, but that we really should be assessing for traumatic stress being present. Like I said, many of these children, that is a risk factor. We know that if you've experienced traumatic stress, toxic stress, there's an increased role that it plays in suicidal ideation, self-harm. So also embedded within this model, within screening, having a trauma-informed care approach. So it's not only going through the questionnaires, but it's also when you do identify that a child is experiencing, chronic sadness, hopelessness, that you have both the psychoeducational resources to teach them about that, provide that supportive environment and network, and then determine what are their social needs. Is this a child who needs to be connected to basic services? So something like a food assistance program. Is it somebody who is living in poverty and needs other things like clothing, or electricity was turned off? Again, so we've got to think more broadly too about kind of the social determinants of health and what we can do to mitigate some of those trauma factors, even assessing for bullying, and certainly any experiences with abuse or harm. Next. Okay, so you can go to the next slide. So let's say the prevention pieces, they didn't work along the way for a number of reasons. Like I said, it could be that not connected with mental health, or someone that is recommending that they go to the ED because just not really confident about the safety plan. And then sometimes we do have children and families say, well, we can't commit to the safety plan that you've created for us, right? And so then sending them to the ED is necessary. So once we're at the ED, I'm sure you've seen this, and this is in the toolkit, the PMHCA Technical Assistance Toolkit. We need to understand the ongoing kind of care pathway. So if you're working with EDs, specifically on changing that environment or providing needed services where there are gaps, we want to make sure that when children are presenting, that there's a calm environment, there's specific space or rooms that can be used. We're also having a dedicated team who understands that these children are in crisis. They may present with agitation or acute distress. And so how to manage that. We're also needing to train staff on those who have neurodevelopmental disorders like autism spectrum disorder, and so can experience heightened sensory sensitivities, and so those could be ongoing triggers. So in general, just providing education about some of the patient populations that may be presenting that have unique needs. Then screening, of course, is initiated. As I had mentioned, at that point, probably are administering the Columbia Suicide Severity Rating Scale. So we want to take a look at that. I know that some people who are admitted to the ED who have experience, and the reason they're being admitted, have experienced a traumatic injury. We also would provide a screening instrument like the STEP. So, even going back into their record and looking, is this someone who's had a traumatic stress injury? We want to understand the risk factors that may be leading to their current presentation. Then, in addition to those screenings, we want to just get more information about previous self-harm, violence, aggression, both that they may be the victim of, or they may have been perpetrating. Sometimes that's why they're sent to the ED, is due to aggressive behavior, and then just their general mental health presentation. Additional assessments to consider, of course, would be medical assessment, and that's for ingestion or other types of medical concerns. The safety assessment, so both in the current hospital setting, and then, as I had mentioned, there needs to be plans for when and if there's behavioral escalation. And then after all of that, we do want to be consulting if hospitals have the ability to consult with psychiatry, social work. So we want to look at who they have on staff and what type of consultation in areas where there is less availability. Then we want to look at teleconsultation, and that could be telepsychiatry. Even in very rural or frontier areas, now it's about 36 states that allow for, if you have a certain certification, that allow for psychologists to practice across state lines. So again, if we have identified this network of people at the outset, we really can get the services that we need. It's just figuring out who we need to reach out to. And then we're at thinking about if it's inpatient, outpatient, discharge. After that, how do we follow up? Any questions so far before we go on? No. Okay. Next. So potentially modifiable risk factors we want to consider. And what are these risk factors? So we're considering them both on the level of prevention, when they actually present to the ED, and then also upon discharge. So mental illness, of course, what have they been diagnosed with? And depression, substance use, anxiety, do they have autism spectrum disorder? Also impulsivity. And impulsivity is a big concern because typically it's a combination of depression plus activation or impulsivity that leads to a suicide attempt. So we know that of those who do experience depression, having ADHD on top of that, and particularly having difficulty with managing impulses, leaves one at a higher risk. Family conflict, if individuals are living outside of the home, so like in the case of foster care, in general, social isolation, so feeling like they don't belong, there isn't a connection. And then more immediate, certainly within the ED, would be looking at things like intoxication, again, ingestion, agitation, and if there was a recent stressful life event. So it's not that we've had a series necessarily of things that have led up to the current presentation, but we can identify one thing in particular that led to the presentation. We also think about, going back to the Bronfenbrenner, that circular biopsychosocial approach that I had shown, looking at their systems and what are things that within our control or within their control and what's outside of their control. So within the level of the home, child abuse, maltreatment, said family conflict, exposure to domestic violence. In the community, we'd want to think about neighborhood poverty or violence, society as a whole, could be racism, lack of economic opportunity, or marginalized populations. And that also includes transgender youth. So we want to, again, think about all those systems and how those systems interact. Next. Protective factors that we want to assess for and bolster. Having secure attachment, so having one caregiver in particular or one adult that's a healthy, positive influence, leads to secure attachment, someone that they know that they can rely upon. Authoritative parenting styles, so we don't want the authoritarian parenting style where very harsh parenting is used or corporal punishment is used. We also don't want, on the other hand, permissive parenting where we don't have those guardrails or boundaries. Positive peer interactions, and then also having a positive partnering between school and family. So family, parents knowing what's going on at the school and being involved in some of these prevention-based strategies, these school-wide policies, the anti-bullying initiatives. We want that collaboration. Individuals who have high self-esteem, well-developed emotion regulation skills, kind of goes back to being able to manage impulsivity, connectedness, whether that's to peers, school, neighborhood. And then we always want to look for opportunities for mentorship. So if not within the home, then what are community-based programs? Big brothers, big sisters, and there are other, local organizations too that offer that. Next. So I'm sure that you've seen this from the EMSC, but it's ED screening and treatment options. And this is coming from ED Stop, which some of you may have participated in. But in addition to kind of conducting the needs assessment, we also want to think about at the point of getting prepared for discharge, what's really needed. And so within the ED, within the hospital setting, there really needs to be a presence of a written process that everyone understands and is following. And that includes like a safety checklist for safely discharging the patient. There should be a resource packet that families are receiving. So, as I had said, about psychoeducation, about the symptoms, some basic coping skills, and then where to go or who to contact if we're starting to have increased suicidal ideation or further needs are needed. And then also lethal means restriction and counseling. These are all critical pieces that should happen before the patient is discharged. Next. Some more information about preparing for discharge. These are some of the things that we want to think about. SAMHSA had come up with, and maybe you've seen this protocol, but that there'd be someone to talk to, someone to respond, and then also a safe place to be. And so that's kind of like a tiered level of services. So someone to talk to, we want to look at crisis hotlines, such as 988. I understand that in some states, they're still working out the details of how that works, how they can serve everyone in their community, how it can be sustained. But in theory, providing the infrastructure for someone to speak to. And then we would go from if, that isn't enough, right? Or ideally, what should happen is if there's concern and it elevates or rises to that level of concern, then someone from 988 would contact and coordinate for someone to respond. So then someone to respond is looking at mobile crisis teams that can support youth wherever the crisis is taking place. And so that would include doing a risk assessment for suicide, also doing safety planning, psychoeducation, referrals, transition to acute care settings, and in places where they don't have that coordination between 988 and then the mobile crisis. A lot of times then we are working with law agencies. And so with the law agencies or with the police, that's another area that certainly we could work on as a team, one of those systems of care that we need to strengthen. And, there are national initiatives to incorporate social workers more when responding to needs within the community. And then if we think about, okay, someone to respond, we have a mobile crisis team and then a safe place to be. So in some communities, they do have availability of a crisis stabilization unit model. So where is there a place that we can have a bed for about 24 hours or so? Without having to go to the ED. And we know that brief for stabilization, that model is just, if not more successful, when the child does not need to have a full admission. So what we find is readmission to the ED or presenting to the ED again, if you've been already at the ED or if you were at a crisis stabilization unit, that it still ends up being about the same in terms of presentation or risk factors. Additional things that we want to consider for discharge. We want to ideally be able to have a follow-up appointment that's within 72 hours of discharge. So who is that going to be with? And that's often one of the challenges within the community. Sometimes behavioral health providers aren't available. There's such a shortage of behavioral health clinicians and psychiatrists. So then this goes back to the medical home. So really coordination of care with primary care providers. We do want to be able to facilitate a phone call or follow-up communication to the primary care provider or outpatient clinician. I'm very much aware that sometimes their patients present to the ED and the PCP has no idea that occurred and just sees them months later, or they present, sometime soon thereafter, and they only find out through chart review. So we need to have increased support through the primary care system. As I had mentioned, we want to discuss lethal means restriction. So access to weapons within the home, we always want to be asking about that. And medications, having medications, locks, and sharps locked up, and having those systems in place and documented. Review the discharge and safety plan, the follow-up, resources with the patient and family, even using crisis cards with contact information. So wherever that child is at, child has one, parent has one. And then consider a contract related to safety issues. So again, that goes back to locking up, sharps, weapons, having lock boxes, and then providing a family resource packet. Next, I'm sure that the systems within with which in you work use the Stanley Brown or some version of the Stanley Brown safety plan, but that is the one that's most familiar to EDs and what's typically used. But regardless, the key areas we want to hit are, what are the warning signs for the child? And of course, the patient, the child has to play or should play an active role in this, as well as the parent. What are some coping strategies that can be used when starting to identify some of these warning signs? People and social settings that can provide distraction that are positive. Also, people that you can ask for help during a crisis. I always ask for children to identify adults and make sure that they have adults in this plan and not like just friends, because that's really, really important. And then professional agencies or contacts. And then at the bottom, you can see what are the plans to make the environment safer. I also like to add to this safety plan, and this is something that we have in our rainbow safety plan, is what are things that I'm looking forward to. So reminding them of some of the things that are to come that they can be hopeful about. What are some protective factors? What are the reasons that they remain to keep themselves safe and committed to the safety plan. And for some people, it's because of a sibling or a pet, or they're looking forward to being promoted to the next grade. So whatever the reasons, we need to explore those. I have had patients discharged from community EDs before without a safety plan in hand. So the safety plan may have been completed within maybe their EMR system on the hospital end, but the patient leaves and doesn't have a packet, doesn't have this information. And so although it's discussed, patients aren't going to remember the content. So it's really important that this is provided and that they've played an active role. Next. These are some resources that are specific to suicide prevention, safety planning, and then also just in general, like some things you might find helpful, like coping cards. So you might want to take a look at those a little bit later on. I also have found a few others that are helpful. More and more, we're trying to lean into use of apps for mood tracking. So MindWise has an app. Some of the other things that are helpful for thinking about peer-to-peer support. There's an organization that's called Seize the Awkward, and they have a whole website of resources. And again, it's for peers to connect with each other, to establish the community or a sense of belongingness. There's also the JED Foundation, which is supported by the American Psychological Suicide Prevention Foundation, and take a look at some of those resources too. And then there's even an organization or a program that is being developed for schools and is launched in think over 9 schools at this point, and it's called Trails. And so it's a suicide prevention program that looks at providing social and emotional learning and CBT. And so that's just embedded within within the school and the academics. I know that there are some schools too that for grade school, they're already starting mindfulness programs or social emotional learning programs at a very young age, zones of regulation, just to get kids talking about identification of feelings, and then also what are some possible coping skills. And then things that I'm sure you're familiar with, like NAMI, right? So also not just at the medical level, but also in the neighborhood support. Next. So then after a patient is discharged from the ED, or we're thinking about even a patient who ended up being admitted to a CAPU or inpatient, regardless, again, that goes through that whole healthcare continuum. We're still thinking about what can we do, prevention, intervention, and follow-up. And so from the emergency department, there can certainly be, in terms of where you provide support, increased education on screening tools or standardized protocol for when screening tools are used. And then also, how do we provide that trauma-informed care approach to discussing the scores on those tools, available web-based learning modules. So certainly through EIIC, they have like the peak suicide modules. There are also virtual learning opportunities through ED Stop, equipping emergency departments with community mental health resources, but doing the work for them to determine who is taking openings, what insurances they take, all of those things on the front end that there really isn't, in the moment time to do. And sometimes we don't have 24 hour social work support. So again, we want to make sure that the connections that we're recommending can be made. And then the consideration for teleconsultation and creating a database of who's available. Within primary care, as I had mentioned, again, education on screening tools, making sure that's part of the standard practice, that we're not defaulting to the information just that's being provided, but that we're screening everyone. That we do provide education on safety planning, what that involves to increase confidence so we can keep kids at home who can still be managed within the home. Also connecting primary care to teleconsultation. So again, whether that's behavioral health clinicians, psychiatry, or in some states they have access lines where a PCP can just call, and that's state supported, that's supported through PMHCA dollars in some cases. And then also working with how can we expedite follow-up appointments within, back to primary care or to the mental health clinician. How can we bridge? Because we're going to have to work as a team to try to make these 72-hour requirement. And we do know that that's a significant protective factor if we can get them in to see some medical professional within that window of time. And then looking at the school. So again, safety plans at school. What are triggering events for particular children? Are there certain risk factors that we can identify early on? And again, provide the prevention for making sure that we're establishing a sense of belongingness, community. If this is someone that is identified as having ongoing mental health difficulties or challenges, do they have 504 plans, IEPs in place? What is their specific coping strategies that they can be using at school? Connecting them with community mental health resources, and for the school to just staff to be able to identify what might be signs or symptoms for concerns, and any opportunity we have to embed the social emotional curriculums. And some things that we need to think about too, in terms of SAMHSA also identified levers of community resilience. And so we know that communities are stronger when we have established these support networks. So like what I had shown with the AAP emerging threats graphic, We want to develop systems to promote community mental health outreach, education, and training. We want to establish mechanisms to promote community empowerment and decision making. So we know that when communities are more engaged, even on the neighborhood level, that leads to increased, of course, civic engagement and increased sense of connectedness, and serves as a positive buffer. Group interventions at schools. So maybe we don't have the staffing to do one-to-one, but there are models like cognitive behavioral intervention for trauma, like at school, and it's a brief CBITS, it's a brief intervention model. Others are looking at inserting psychological first aid or skills for psychological recovery, that would be something embedded within schools and delivered in a group model. Also, we need to think about the digital divide that might exist. So for some of the families that rural, frontier, or just live in areas where there may be higher poverty, less access, what kind of financial assistance, what can we do, how can we problem solve? And a lot of this is for those individuals who are of greater need, problem solving, using motivational interviewing strategies to figure out what can we do, what solutions do we have, can we connect to libraries, can we get private rooms when we're at the library? So thinking about that in advance so they can connect with providers even if it's not right in their community. Buffering effects of multiple disasters. So we know that's also a risk factor too. Mood tracking apps and shared plans of care. Okay. So you can go to the last slide. So just wanting to talk about barriers and accomplishments. Any challenges that you've encountered, solutions you've identified, how we can problem solve together, questions. You discuss anything on this topic or topics.
I can hear the intense thinking, but nobody's brave enough.
Anything? Oh, maybe Jessica is
I have a
unmuting.
question. Yeah, I have a question about
Yes.
suicide assessment risk. Yeah. So you recommend using the ASQ screening. How do you think that compares to like the Columbia Suicide Severity Rating or the Suicide Behavior Questionnaire revised assessments?
Yeah, no, that's a good question. So we've transitioned to ASQ previously in primary care. So previously we were using the PHQA. So I think the ASQ is kind of a quick and dirty approach, couple questions, and then being able to provide and follow kind of the decision tree for identifying additional questions that might be asked. So the benefit I would say is for that model is maybe time. And then also sometimes kids are a bit, depending on the age level in terms of, should say, developmental ability. The Columbia Suicide Severity Rating Scale can be sometimes a bit confusing, we find. So just considering that, but certainly the Columbia Suicide Severity Rating Scale is when we know that the child has suicidal ideation, and we really need more information about that and the severity and the frequency and intensity.
Okay, thank you.
Sure. Any other questions that people have?
Kim, if I might, we are going to go ahead and launch an evaluation survey. We'll take everybody's please patience to complete the survey. We would really appreciate your input for further planning of our activities, and you should be able to see it now. Let me know if you don't see it. It's 5 questions, so it shouldn't take more than a few minutes. really appreciate it. While we're doing your time and doing the survey, please take the time and ask questions. We can still continue the conversation as we are completing the survey.